to spin. And when an implant starts spinning, what does it mean? That we lose what? The primary stability. And if we lose the primary stability, we cannot perform what? The
Immediate load.
okay? So always be cortical. If you do nasal implants, be cortical. If you do zygomatic implants, be cortical. If you do pterygoid implants, be cortical, okay? Because we want to avoid this situation, the spinning of the implant, okay? Good. So, look at this case, okay? This is a common clinical case because we use pterygoid in full arches, but the daily clinical case that presents in our office is the partial posterior rehabilitation, when patient asks for the partial rehabilitation in the posterior part of the maxilla. Is it right? When they have a failure of 1-2 molars or 1 premolar and they want to restore the posterior bridge. Is it right? Okay. Look at this patient. She had 2 failing molars in the posterior part of the maxilla. And she asked me for a solution. So I offered her, dear patient, we can do a bone augmentation there. Okay, vertical bone augmentation in the first and second molar region. Obviously, we have to wait. In the best hands in the world that they are not my hands, because my hands are equal to yours. Okay, I'm a normal surgeon, I am a normal dentist. We have the 65-70% of success. These are real percentage of success in bone augmentation. Or we can extract the second premolar. Was it healthy? Yeah, it was healthy. But I proposed to her a second option with a strategic extraction. We extract the second premolar, I put up pterygoid implants posteriorly, and we solve the clinical case. The patient choose the second option, okay? So 1 hour of surgery, less than 1 hour, and an immediate loading rehabilitation, okay? This was my surgery, and you see that was done in the past, because in the past I used to screw and to put straight MUAs in the pterygoids. Now I prefer to use 70-degree MUAs, and we are going to see why and which is the purpose of 70-degree MUAs. And I prefer to restore and to rehabilitate the patient with multi-unit abutment, because I follow the concept of one abutment, one time, in order not to interfere with the connective tissue during the healing. Okay, and this is a rehabilitation that has been working for more than 10 years. Okay, this year, so they work very, very good. Okay, is it clear till now the concept? Any question? Yeah.
Can you show us how to measure by the CBCT the distance to arrange the length of the implant?
Yeah, you can infer more or less the length of the implant from the CBCT.
Right.
But when you drill, how do you understand which implant you are going to put? Because you drill.
Yeah.
And when you drill for pterygoid implants, you always have to feel with your hand this sensation. First of all, you are drilling in the soft bone, the tuberosity. Then you face something hard, that is the cortical. Then you fall down something inside a chamber, okay, a fossa, okay? So you don't feel any resistance. When you are falling down, you look at the laser mark, you see the laser mark, and this is the length of the implant that you are going to use, okay?
So the CBCT can't decide sometimes.
Yeah, maybe you can preview that you are going to use a 15 or 18 millimeter implant,
right.
Okay? But you are not sure 100%. So you must have in your stock 15, 18,
Ready,
20,
all ready.
okay? All the range of implants, okay?
Thank you.
Any other question? Okay. Now we have seen the theory, we have seen from the radiological point of view how we can plan a pterygoid implant. Now we see some pictures from cadaver, because we want to start touching the real anatomy. So what is it? The tuberosity, okay? This is the lateral pterygoid lamina. This is the medial pterygoid lamina. What is it? The posterior wall of the maxillary sinus, okay? Because we are watching this maxilla from vestibular, okay?
Yeah.
Perfect. In the pterygoid fossa, what do we have? What is this brown tissue? It's muscle, okay? Only muscle. So from another point of view, okay, tuberosity, lateral pterygoid lamina, medial pterygoid lamina, pterygoid fossa with muscle, posterior wall of the maxillary sinus. And remember the first concept, the pterygoid fossa, our target point, is always medial respect to what? To the tuberosity. Now I want to introduce you another anatomical region, only to train your brain and your mind, but I don't give you the meaning of this anatomical region. Behind the tuberosity, we have this incisura, okay? The retrotuberosity incisura. What does represent this incisura? The base of the pterygoid fossa. And between the tuberosity and the pterygoid fossa, what do we have? The pyramidal process of the palatine bone, where we find the cortical bone, okay? So this incisura represents also what? The base of the pyramidal process of the palatine bone, okay? So it will be the anatomical landmark that is guiding me toward what? The pterygoid fossa. Do you remember at the beginning I told you, okay, in literature we can read about the inclination, the median inclination of pterygoid implants from 5 to 15, from 5 to 20, from 5 to 30, okay? But how will be the right inclination, okay? We have to be guided from the anatomy. And this incisura, it represents the medial inclination of my implant, okay? Do you understand this concept? Because it's important, because it is underlying all the pterygoid surgery, okay? How much medial I have to go in order to engage the pterygoid bone, the cortical bone, okay? So this is the inclination from medial to distal and from lateral to medial. And you see the bar is entering inside the tuberosity, the alveolar socket of the third molar, is following the middle part of this incisura, and it's ending inside the pterygoid fossa. Okay? Clear?
Yes.
Good. And this is the JD pterygoid implant. How is designed this pterygoid implant? We have a rough surface where we expect to have the osseointegration and a smooth surface anodized into the first 4 millimeter. Why? Because we expect to have some bone resorption in the tuberosity, because the tuberosity is a bone with a lack of cellularity inside, okay? We don't have so much bone marrow, we don't expect to have an osseointegration there. So we have also a healing pattern that is different from the other part of maxilla and mandible. So having some bone resorption there, we reduce the risk of periimplantitis having a smooth surface there, okay? Good. And this is the implant inserted, viewed from different point of views, okay? And look, this is the best picture that you see in your life about pterygoid implants, because it describes perfectly the anchorage in the pillar. So after having put the pterygoid implants, I removed the bone of the tuberosity, and what I found inside? Nothing, because there wasn't bone. I had only the cortical of the tuberosity. So expecting an osseointegration there is a gamble, okay? So we cannot trust in the tuberosity for osseointegration, but behind the tuberosity, going back, we have this cortical bone. And what is it? The cortical bone of the pyramidal process that stabilizes our screws. And look at the tip of the implant is inside the pterygoid fossa, okay? Good? And look where is the maxillary artery. It's far, okay? Completely in a different region, okay? Good. We have also published with our friends, with Tommaso, with Rawad, that is going to speak about pterygoid tomorrow with a new tool for probing the cortical bone. And we have seen in our surgeries that this implant works very, very good. And it has the same survival rate and success of normal implants, more than 98%. Okay, so we have studied pterygoids after 1 year, after 3 years. Now we are publishing after 5 years. We'll publish also after 7 years, we hope, in future, and it works very, very good. So that's why it's an implant that must be placed in every situation that where we find a tuberosity, because it improves all the rehabilitation in a very, very effective way. Okay? Many colleagues also, they complain about pterygoid surgery, about the invasiveness of this surgery. But pterygoid implant is a really minimal invasive surgery, because it's like that. I raise a small flap starting behind the tuberosity. I fill with an elevator the incisura, because it's telling me how much medial I have to go. I drill 300 RPM without water, because the bar must tell me in which side, in which bone I'm drilling, okay? I use only 3 bars, 2.0, 2.4, 3.2, and then I insert my implant by hand, okay? By the hand surgical driver. Why? Because I want to have the perfect control while inserting the implant. I don't want to change the inclination of the implant while inserting it. Then I want to be fast. I don't want to put inside the mouth of the patient too many things that they can detach from the branch and they can go inside the throat, because we are working in the posterior part of the maxilla. So I work by hand and it becomes an easy game, really easy game. And this is the healing that we always have in this part, in the partial rehabilitation in full arches, with a lot of keratinized tissue and no inflammation. And why we have this result? Because I'm better than you, because I have perfect, better skill or particular skills? No. Because I'm following a protocol, I use the intermediate abutments like the multi-unit abutments, so it's easy, okay? And I'm respecting what? The biology, okay? Stop. And by respecting the biology, we have these results, okay? That they are beautiful pictures, but I didn't do anything special. I only know a good anatomy, I only know the anatomy, and I only know the protocol. And this is a CPCT took after some years, and you see here we were lucky, we didn't have any bone resorption. The tip of the implant is inside the pterygoid fossa, and you see tuberosity, low density, then white bone, the cortical bone of the pyramidal process, and the pterygoid fossa. Okay? So, now, any question about this clinical case? Yeah?
Filippo, about your experience, what kind of prosthetic corrections do you prefer? Internal corrections or internal hexagon?
Yeah.
Or is
Yeah, I prefer a lot. With the screw vent connection, okay, it's more easy in the posterior part to put the multi-unit abutment.
Okay.
Usually I prefer to put a conical connection, but with conical connection it's quite difficult, especially in the posterior part, to screw the multi-unit abutment, because you have the cone and it's quite challenging. But with conical connection, I saw in time that you have a better stability of bone. Okay?
biology too?
Yeah. So I prefer, but you can use also screw vent connection, that it's more easy to screw the multi-unit. Okay? But conical connection are better, 100%. Okay? So, any other question? Yeah?
You showed a picture earlier that you put the implant into a socket.
Yeah.
Do you normally graft that socket?
No, no, only the blood clot.
Yeah.
Okay? I don't put anything because I don't trust in socket preservation for many reasons, and I want to reduce the risk of post-operative infection. Okay? So I only believe in the power of the clot, okay, and the cells. So let's analyze the surgical technique. Yeah, okay?
So if we don't have a
Primary stability.
what we are going to do?
If you don't reach a primary stability,
Yeah. First,
you cover the implant, okay? Yeah, and you wait for the healing. But if you don't reach the primary stability, it can happen. You have to discuss with yourself why, okay? So you have to analyze the mistake that you did, okay, in order for the next surgery not to redo the same mistake. Because with pterygoids, 98 cases out 100, you reach the primary stability, okay? 30, 45, 50, sometimes you reach 80, 100 in the pterygoid area. 30, 45. Even if, okay, we can discuss a lot about Turkeys because it's better to have the, because you can load an implant also with 10 Newton per centimeter. But if it's linked, split with the others, and you have an apical stop, you can load it, okay? But it's a very big, okay, subject, yeah?
Our aim is to reach the palatable, to have the anchorage, right? Have the top.
Yeah.
From the, you say that we analyze the tuberosity and inclination is depends on the anatomy.
Yeah.
Patient. I just couldn't imagine.
How much medial?
Yes, how much we got out the starting point of the dental.
The starting point, yeah, you are going to analyze it. Yeah, good question.
Yeah.
Okay, now I'm going to answer to you, okay? Yeah, because when you use it and then you try it, you feel soft, then you feel the increase of torque. The value, I don't measure the value because I feel by hand that it, yeah, because with this one you can reach up to 100 centimeter. But trust me, you feel that the implant is stuck inside the bone. Okay. Okay. So let's analyze the surgical technique. Okay. This patient asked me for a fixed rehabilitation in the posterior region, and she didn't want to do a full arch. Okay. So, for example, here we had to increase the vertical dimension to disclose the anterior teeth and to rehabilitate the posterior maxilla. Okay. Now here we can do two things. All are large, very big. Okay. Bone graft inside the sinus, but you know, okay, it was a really wide sinus, and with really wide sinus, sometimes it's challenging to do bone graft. Or analyzing the case, I had some bone here, a tuberosity here, okay? So I could put one implant here, and two pterygoid implants, okay? How do I choose the starting point, okay? So what do? I tilt the slice of the CBCT, okay, in this way. So I go distal. When the sinus disappeared with the slice tilted at 45 degrees, I measure the length from the end of the tuberosity, from this part where the slice is tilted, with this maxillary sinus disappeared, and this is my entry point, okay? It's very easy.
So you aim the palatinal wall.
Yeah.
The pipe.
Yeah, okay. From I tilt the slice, I go distal. When the maxillary sinus disappear, okay, this is my entry point. Okay? Good? You're welcome. So you see, very big maxillary sinus, but I had the tuberosity and some bone in the front. Let's analyze the tuberosity, okay? I have the, look, dark bone in the CPCT, so low density, but look at this bone, okay? Very white is the pyramidal process of the palatine bone. So I'm sure that this pterygoid will get a very high primary stability, okay? So let's start the surgery. I raise a flap, okay? I start from behind the tuberosity. Why? Because I want to touch the incisura that represents the base of the pterygoid fossa and the base of the cortical bone of the pyramidal process of the palatine bone, okay? And then I insert my implant. Why I have to start behind the tuberosity? Because in the past I used to put a retractor, an elevator here, touching the incisura, and it was telling me, Filippo, the pterygoid fossa is here, okay? So I have to go against it, and from this idea, I developed the JD pterygoid retractor that we are going to analyze after this clinical case, okay? Another trick. Here I put a 70-degree MUAS and not straight. Why? Because I want to have the prosthetic emergence, okay, that becomes more mesial and a little bit vestibular. Why? Because I want not to die screwing and screwing the prosthesis. I want to make my life easier, okay? So with the long screwdriver, I can unscrew and screw the scum body, the transfer, and the rehabilitation in a very easy way because I have the prosthetic hole and the access that is located a little bit vestibular and mesial, okay? That's why I prefer to use the 70-degree MUAS, okay? And look, with the long screwdriver, I can unscrew and screw everything, the prosthesis, and the scum body, and everything, the rehabilitation, and the multi-unit abutment using the screwdriver outside the mouth, okay? So it becomes easy, okay? And without any dangerous moment. For example, that some parts can fall down in the throat of the patient. Okay? This is the end of the super invasive surgery, okay? 4 stitches, so very easy, preserving the keratinized tissue around the multi-unit abutment. The final X-ray, 2 implants, 10 mm with big cortical anchorage, 2 pterygoids posteriorly, high primary stability. I could move into the medial loading phase. And this is the healing, okay? So these were 2 titanium composite rehabilitation because the patient couldn't afford a zirconia ceramic rehabilitation, but it doesn't matter. Now with composite we can do whatever you want. And after 5, 6, 7 years, maybe she changed the composite, okay? It doesn't matter. But with only 2 implants, no bone grafting, medial loading, and everything, we can change. And we can turn a difficult situation into a simple one, okay? Is it clear? Good. From this idea, this concept, so we summarize everything. The inclination must be from vestibular to medial. Okay, I have to skeletonize the tuberosity. I have to engage the pyramidal process of the palatine bone. How much medial? I have to touch the retro incisura behind the tuberosity, okay, that represents the base of the pterygoid fossa and the base of the pyramidal process of the palatine bone. I designed with the company this instrument. And why we designed this instrument? Because by applying, and we see this part touching the incisura and following this vertical line, okay, stamped, this is a laser line, I'm guided while inserting the implant, okay? I know that there is a little bit of confusion. Now we see some videos, some skin, and then we'll do it in the hands-on. So the first day that I received after my project, the JD pterygoid retractor, I had this clinical case where I decided to put one implant here, and a pterygoid implant here. Okay, so this is a tilted slicer. What do you see? Tuberosity, cortical bone, and pterygoid fossa. Okay, so let's analyze it. Let's see the video in order you to clarify what is the meaning and the purpose of the pterygoid retractor. So, first of all, you use the scalpel and you raise a flap starting behind the tuberosity, full thickness flap. And with the elevator, you see, I go around the tuberosity and I want to touch the incisura, okay? Because it represents my target point. Then I place my JD pterygoid retractor, and it has two aims. First of all, it reflects the flaps, but with the vertical line stamped with the laser here, is telling me how much medial I have to go. Then, from my planning, I decide my starting point. With the bar, I'm parallel to the vertical line here, and at 300 RPM, tilted 45 degrees from medial to distal, because this inclination between the vertical and the horizontal part of the instrument is 45 degrees, I'm guided by my instrument, okay? You understand? So, I have not to think too much. I have only to raise the flap, to skeletonize the tuberosity, to put the retractor behind the tuberosity, and to follow the laser vertical line, okay? And by following that line, I know that I'm guided inside the pterygoid fossa, okay? Is it clear? Good. So I follow the protocol 2.0, 2.4, why? Because the 4.0 pterygoid implant has the tip at 2.4, and then I enlarge the coronal part at 3.2 because I want to avoid any fracture into the tuberosity area, okay? Then I place my implant freehand, okay, with the surgical driver, and you see what I'm doing. Because I was reaching too high torques, I screw and screw, screw and screw, screw and screw, because I don't want to ruin the connection of the implant, and I don't want to reach too high torques that can fracture also the apical bone, okay? In action, okay? Behind the tuberosity, I follow the vertical line, okay? And being parallel to this line, I'm directed inside the pterygoid fossa, okay? Another example, and you see this inclination between the vertical and horizontal part is 45 degrees. So when you put it behind the tuberosity, okay, it is well stabilized by the two teeth that this instrument has, and it tells me how much medial I have to go and how much from medial to distal I have to incline my implant and my osteotomy, okay? And this was the post-op CPCT, and you see the inclination was perfect with the tip of the implant kissing the pterygoid fossa, okay? Good? Any question? Very good. So, let's re-see how this pterygoid implant JD pterygoid retractor works, okay? Our anatomy, tuberosity, okay? Incisura, pterygoid fossa. You remember this picture? Okay. So I raise the flap and I put my JD pterygoid retractor in the incisura, Okay, and this part of the G-deep pterygoid retractor are stabilized by these two teeth. Okay, and then following the vertical line, the laser line that is present on the instrument, you see I'm directed toward what? The pterygoid fossa. Okay? In this way. Having the implant in a perfect 3D position, in a perfect stabilization, and with a perfect primary stability. So let's see the last video and then we start with the hands-on. Okay, this is a more recent case where I performed the classic scheme, the all-on-4 in the premaxilla, then I added two pterygoids. Okay, especially in the right quadrant, I performed a transsinus, but I didn't open the sinus because I entered inside the sinus for only 2-3 millimeter. And also I applied a full digital workflow with the photogrammetry and the scan of the soft tissues and the healing caps in order to have a full digital rehabilitation without impression. So now we see the video about the surgery. Okay. So, you see, after having raised the flap, I clean the bone, I remove the soft tissue because I want to have a clear view of the anatomy, okay? A perfect view of the anatomy. Then I skeletonize the tuberosity. I touch with the elevator the distal part of the tuberosity because I want to feel the incisura, and then I put the retractor. Then I start drilling. I start with the pilot drill in order to mark my entry point. Always 300 RPM without water because I want to be precise. I don't want to have water in the posterior part of the maxilla in order to have a clear view. Okay, then I probe what I'm probing. I'm probing that I'm inside a bone envelope because the bone was very soft. Then I use the 2.0, and you see, okay, I drill slowly, and then when I feel a solid bone, a cortical bone, it means that I am in the right spot, and I apply some pressure, okay, and I perforate the cortical bone, entering inside the pterygoid fossa. And I'm always guided by the JD pterygoid retractor, okay? So I'm not stressed, because even if it's a blind surgery, I'm guided by the retractor, okay? So this is the 3.2, and then I insert my implant by hand, okay? Why by hand? Because I want to maintain the inclination. I want to feel when the torque starts to increase, because with the torque branch, it's difficult to maintain the inclination. With the motor, sometimes we have some part of the mouth that they interfere with us. So with the hand surgical driver, it becomes a game, and you become also faster, okay? The opposite side, okay? I drill and look at the drill. You saw in the tip we had the cortical bone. It means that we perforate the pyramidal process of the palatal bone, so the implant will get for sure a good primary stability. Then, after having put the two pterygoids, I start with the normal implants. Okay, that is a sort of game. The two tilted, anchored in the base of the nose, and the two anterior implants anchored at the base of the nose in order to increase the primary stability. So always the same. I start drilling, then when I face the cortical bone, I push a little bit, and this is the length of the implant that I'm going to put. Okay? Then I use the bone track drills. Why the bone track? Because they permits me to have the perfect prosthetic axis of the implant, even if I under-prepare the site. I use them in the palatal approach and the post-extractive implant, okay? And then I insert my implants. In this case, I'm using all the implants with the conical connection, okay? Because I prefer to use the conical connection, but putting MUAs is quite difficult. And you see the other tilted implants. Look, I am anterior to the maxillary sinus, okay? I use the bone track, then I insert my implants. Tack, okay? Bone track in order to correct the inclination, especially the prosthetic inclination of the implant, because I prefer to start palatal in order to leave some bone vestibular, in order not to have any soft tissue recession and bone resorption there. And then I put my MUAs, you see, okay? Then I use the photogrammetry. This is the tuple, the fastest photogrammetry that you can find in the market. It takes 4 seconds. Then I screw the scam body on top, I stitch, and I shoot her, okay? And then I take the intraoral scan. That's it. You send everything to the laboratory, and you can deliver a really passive rehabilitation, very precise in occlusion. If you put the tracer in the palate, my advice is to put 2 tracers, not only 1, because you have a better control of the occlusal plane. This is the intraoral scan. Here I put only 1 tracer. Now I put 2 tracers. 2 pterygoids and a classical all-on-4 scheme in the front. Okay? So look at this anatomy, because not every anatomy is the same. Sometimes we have the pterygoid fossa that is very medial. That's why I told you at the beginning, oh, I read from 5 to 15 degrees in inclination from vestibular to palatal. But from 5 to 15, they are numbers. Sometimes it's 45 degrees toward medial, okay? Look, this is a difficult anatomy, but by using this retractor, I put it in the incisura, I'm guided, and you see, I have this pterygoid implant that is perfectly stabilized inside the pterygoid fossa, okay? And not because I am the best implant surgeon in the world, but because I'm using the right tools. And if you use the right tools, if you use the right instruments, if you are using the right implants, you can achieve this kind of result without being stressed and without having concern about the surgery, okay? Any question about it? This is a semi-guided approach. So I plan my implant, okay? Look, I had a very narrow tuberosity here, so I prefer to perform a semi-guided surgery, so having the first osteotomy be guided, and then I ended it by hand. You see, the 30 slice, I go distal, 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 and when I don't find any bone, any maxillary sinus, this is the perfect inclination of the implant. So I do my surgery for the first osteotomy guided, then I open a flap as usual, okay? I finish my osteotomy freehand, then I put the 70-degree MUAs with the long screwdriver, okay? This is the inclination, okay? 70-degree MUAs, the healing, okay? Always the same. The scam bodies, look at the long screwdrivers, how they help you. And the final rehabilitation. Look, zirconia bridge without ruler, okay? For example, do you want to improve the thickness of soft tissue here, okay? It's easy, you take some connective tissue from the tuberosity and you harvest and you transfer the connective tissue there. You grab that side. So it becomes better, a better rehabilitation without increasing the invasiveness, the invasive of the surgery, okay? Perfect. We can start with the end. So lateral pterygoid lamina, okay? This is the lateral view. Because we have the zygomatic arch and the zygomatic body, okay? Lateral pterygoid lamina, medial pterygoid lamina. Now here we have the incisura behind the tuberosity, that is the real target point. Why? Because it represents the floor of the pterygoid fossa and the floor of what? Of the pyramidal process of the palatine bone, okay? Where we have the cortical bone. You see, the floor of the pterygoid fossa, because the implant must end inside the pterygoid fossa, okay? Here we have the tuberosity. Okay? Here we have the palatine foramen, where we have the emergence of what? Of the
Greater palatine artery.
palatine artery. Okay? Good? We have usually a posterior maxillary sinus, recess of the maxillary sinus that is like that. Okay? Maybe like that. So we plan to start from here, okay, with a 45-degree inclination. So first of all, we have to raise the flap. We raise the flap, we raise the flap, vestibular, we raise the flap also in the palatal side. Please pay attention to the palatine foramen. If you want to be protected, you put a finger over the foramen that tells you where is the foramen, and then you raise the flap, okay? Then you localize the incisura, okay, with your elevator. Then you take your JD pterygoretractor that has two parts, one for the right part, one for the left part, one of the right, one of the left. That is the right part of the patient, okay? Then you put your retractor kissing the incisura, okay? And the vertical line is telling you how much medial you have to go. Is it clear? Okay. Then you start. Okay. You see the vertical line, okay? The laser stamp vertical line. You have to be parallel to that line. Trust me, this instrument makes a better surgical field, a clearer view, and also it reestablishes the trajectory in your mind. So during surgery, you become really quiet when you insert this implant, because you are not guessing an inclination. You are guided by the anatomy. Okay? So take the retractor. Okay? So you decide your starting point. Okay? And you must be parallel. Okay? You must be parallel to what? To your vertical line. Okay? Stamp. Okay? Then you have this inclination that is 45 degrees between the vertical and the horizontal part. So you have all the inclination. You are parallel, 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 12, and you have, okay? And you see where is the tip? The tip is inside the pterygoid fossa. Okay? Clear?
Yeah.
And you are guided by what? You are guided by the pterygoretractor. You are parallel in this way. Then you take out the 2.0 bar. You take the 2.4. Why the 2.4? Because the tip of the implant is 2.4. Okay? Look at the inclination. I enter inside. I don't force the inclination. I follow the path. I follow the path. Look at my finger, my thumb. I'm not pressing. Look, I'm sliding inside the osteotomy. I'm sliding inside the osteotomy. Okay? In order not to change the inclination, you see, I'm playing with the motor, okay, and the headpiece. And then, look at me, use this bar. This bar is the most clever bar that you can find inside the Pterygoid box. Why? Because the first part of the bar is 2.4. Then it becomes 2.8, then 3.2, right? Why? Why we have these 3 steps? Because it is guided by the other bars. And why is important? First of all, because it enlarges the most coronal part in order to avoid fractures of the tuberosity. But it has another purpose, and you know which is the purpose. That usually in the pterygoid area and the tuberosity we have soft bone, okay? And having soft bone, if we don't follow a precise path, a precise osteotomy, the implant can change the inclination. And if it changes the inclination, we can face a step of cortical bone that it blocks our implant, and the implant starts to spin. Okay? So by using this bar, the implant is guided also in the first part of the osteotomy. Chi è che l'aveva pensato quella? Ah, te? Ah, quella frase lì è... Ah, è intelligentissima. Esatto, lo so. Look, first of all, I start with the finger, okay? Because I don't want to apply too pressure and I don't want to push, okay? Then I start changing the position of my hand in order to increase the power that I am applying to the implant. Now I have 2 torques, so what do? I screw and screw, screw and screw, screw and screw, in order to reduce the torque, ok? E lo sai quando ho capito che è geniale? Dopo anni, perché ho cominciato a non usarla, passavo la 3,2 alla 2,8, a un certo momento cazzo mi cominciavo a spinare gli impianti inserendoli, no? Quella lì è genialissima. You screw and screw. Questo è bello. And look at this implant, 2 torque, perfect. And you can build an house over this implant. So let's train.